Welcome. It's great to have you on board. This is Shabir Musa, the Executive Coordinator of AfroPHC. I'm hoping some of the other members of the board will be able to join us and join me on this platform. Welcome. This is a workshop that we intend to have as an exploration. It's great to have you of community health worker support and ways in which we can explore that. We're very fortunate in having a few speakers that are going to be able to share with us their experience.
Deux panélistes aujourd'hui qui
just want to quickly suggest that if you are able to do your translations, let me just quickly stop the share. If you go to the translation, you could in fact
si vous optez pour la traduction, vous pouvez.
So let me just quickly make sure I've got the English version. So if you're needing translation, please go, and Alexandra will be translating to French. We'll get some feedback later if there's need. So please don't feel limited. But please, if you are in English speaking as well, if anyone speaks in French, just go to the translation interpretation. At the bottom, you'll see you have that sort of globe. Click on it and choose English. Otherwise, you might struggle with French and not having any translation. So welcome to all of you. As I said, we're very fortunate in having speakers that are going to be able to share with us some very important insights. For starters, we have Dr. Ravi Ram, who's a health systems evaluator and specialist with interests in community health, equity, gender, and social accountability, and primary health care UHC. He's based in Nairobi and focuses on South-South collaborations and activism with the PHM, COPASA, and the Kampala Initiative. We're going to ask him to speak about the Social Participation Handbook for UHC that has just been released by the WHO and in collaboration with him and other key stakeholders. After this, we're going to talk to 2 to 3 community health, or people with community health worker background, Danny Gatto and Mary Mulenga, who will later share, and I think we might have Tiameka Goliati from Malawi. So let me stop there and welcome all of you and welcome our speakers. Ravi, thank you very much for joining us. I see you, I don't know whether you want to share any slides. If you do, I can just make sure that you have access.
All right, thanks very much, Shabir. Very good to see everybody on the call. Very pleased to join you today and looking forward to a discussion. Shabir, I will share, so if you can enable that sharing facility for me.
You should have that coming up now.
All right. And what I'll do is I will also share a link so that everybody has a link to the main, here we are. I hope you can see my screen.
Can. Thank you very much.
Fantastic. So I'll share a link so everybody has access to the handbook. I want to make sure that you have all the information that I'm able to share. I'll also share these slides. So if I'll share that with Shabir, and yes, Shabir, you may put it on the AfroPHC website so that everybody can have a one-stop place to find these. So as Shabir said, I'm with the People's Health Movement in Africa. I'm also a member of the steering group for the Health Workers for All Coalition. And that's an international grouping. Several of us in the AfroPHC network are in both of these networks for PHM as well as the coalition. What I'm going to do is just give you a brief overview of the recently released Handbook on Social Participation for UHC, and that's published by WHO. We'll go through chapter by chapter so you know what's there, and then we'll see what are the kind of implications that are there for primary healthcare, community health workers, and civil society and health more broadly. Alexandra, I'm going to speak just a bit slowly because I know I wasn't able to share the slides with you in advance, but for all participants, these slides will be available again. And I do hope that if I can finish quickly, we might have a chance for a discussion.
Certainly.
So very briefly, as a background, the World Health Organization, WHO, worked with a group of civil society actors to develop this handbook. It was a 2-year process, a little bit more than 2 years. And it actually involved quite a good swath of civil society groups. My understanding of these groups is that none of them actually included direct community health worker representatives. And so we'll see that reflected in the handbook. It's still relevant for those of us working in community health, but it's not directly speaking to us. It's more broadly targeted across civil society. Within WHO, it was the Health System Governance and Financing Unit that put this group together, this handbook together. Now, the initial launch was back in December on UHC Day, 12th of December. And then just 2 weeks ago, there was a broad launch for Open for Civil Society, in which the final handbook was released. That means it's very fresh. It is very new. It's had a lot of time for internal review, for the consultations with civil society, but in terms of practice, those of us who pick up the handbook now will be the first ones to do so. And I think that's important. It is a major step forward for WHO in its work with civil society. I think recognizing the technical aspects of how should governments respond to civil society, how should governments engage with their populations, with their communities, and with organizations working in health. It's very important. It is geared toward government. And we in civil society need to take advantage of this handbook to understand here are the main frameworks and guidance that WHO is recommending for our interactions with government, and then make sure that policymakers, governments, local and national levels and provincial levels are well aware of the handbook and begin to use it. I'm seeing it as a new baseline. It's not necessarily cutting edge. It's putting together everything that's a best practice. But we should see in civil society, we should see this as the starting point. We want to push government forward. And so I think it's a credit to WHO that they've reset the baseline so that we have a new starting point. And as I say, it very much strengthens the technical guidance around social accountability for health. Some points to keep in mind. Let's focus on universal health coverage, not primary health care. And they are very different, as we know. In an ideal world, universal health coverage would promote primary health care. In the real world, that doesn't always happen. And so we need to be very careful about how governments in general are moving their UHC programs forward. And when we use this handbook, we should make sure that we are keeping PHC in mind where it says UHC, because they're not always the same. As I mentioned, it is very much focused on government and not necessarily on the health workforce. That's not a disadvantage because we have many tools and guidances for us. This is something that we can then sit down with people in government and say, here's what we need so that we can have a productive relationship and move things forward on that basis. And as I say, it really does build accountability within the health system and not just from the health system to populations. I'm seeing that as very relevant for our group today because we are focused on community health workers. With that, I'm going to now borrow some slides that the Health System Governance and Financing Unit has kindly shared. I want to give some credit to Deepa Rajan in WHO, as well as her colleagues Katya Rohr, Kira Koch, and Marjolaine Nakot. They're the ones who really focused on or dedicated their lives to making this handbook come to life over the past several years. There are 7 main chapters here, and here's the overview. Number 1 is what is participation? And it's about giving, as you see, voice, agency, empowerment to people who don't have that position in the health system. Now, the handbook is oriented toward communities and to vulnerable populations and to civil society groups that represent them. But I believe it's equally relevant to health workers who don't have the power and standing to be able to make changes that benefit the people they serve, as well as enhances their ability to serve others in the health system. So I'm seeing community health workers and other frontline health workers as key constituencies who belong in this handbook. Chapter 2 looks at the enabling environment, and that's not just the regulatory environment, it's the laws, it's what kind of legal instruments can we rely on, more so that government government policymakers and authorities can feel comfortable that social participation is not something that they're doing that's going to contradict a policy. It's actually part of the laws and policies. Then chapter 3 looks at representation and how is participation structured. I think that's very important for us. First, we know that very often many groups tend to be dominated by men, and we have to make sure that we've got that gender balance. Second, we need to make sure that we've got all groups represented, and that's in the handbook. They talk about equitable participation among vulnerable communities. I would say also let's include health workers and community health workers specifically. I'm speaking to you from here in Nairobi, Kenya. We have a very strong community health worker, community health volunteer cadre. The government still refuses to actually recognize our community health workers as formal workers in the health system. The next cadre up, the community health extension workers, are recognized as formal members of the health system. And that's something that I see as a key advocacy point for us in East Africa about what we need to do to enhance the standing and the ability of our community health workers to deliver for their communities. So that's where I see chapter 3 as being relevant for us in the community health sector. Engagement across governments, communities, and civil society is the main topic for chapter 4. Moving ahead, it's what do government people do with all of this engagement? There's a very good point that's made, and we'll see it coming up, that engagement on its own should be a standalone goal. It's not something that's just a means to an end. Without that engagement, government doesn't really know, it doesn't have a pulse of its own people. The fact that we have in many countries some level of democracy, we have elections, that builds in a modest level of accountability. But if we want real accountability for health, we need to have these ongoing interactions. And so what do we do with it? Then we take it forward into decision-making. That can be at a budgetary level, that can be at a policy level, that could be on a service delivery level. There are multiple levels in which it can take place. Coming back to, again, help our government people know what to do with engagement or social participation. It's, again, coming back to the legal frameworks. We saw in chapter 2, there's a look at the enabling environment. It comes back again because the handbook is really to help government know what to do. And then finally, how do we sustain this participatory engagement? It's so that it's not a useful intervention, let's say at the start of a UHC program, to make sure that primary healthcare is front and center in UHC and then disappear. No, we want it to continue. So you'll see at the bottom, I've included some icons because I am borrowing slides from WHO. That's the World Health Organization, the UHC 2030 collaborative. It's hosted by UHC. And then also the Health System Governance Collaborative. That's one of the key network within WHO that's taking this forward. Okay, so taking a look at some of the operational chapters here. We have chapter 2, looking at the power dynamics and what is it that creates a productive or a disruptive engagement. And so we're looking at the structural barriers, and this is really things that we in civil society know, but we need to make sure that government sees it, and having the WHO publication is a huge step forward. So the enabling environments, it's seeing how do we want to structure the kind of engagements that we have? What are the people who need to be involved? How are those people going to step away from their roles in the health system and in their communities so that they can engage as equal members, as people? I'd like to be able to have a further discussion with this group as we go forward. And again, the link will be in the chat box. Moving ahead, let's find the right kind of representatives. That we talked about people. So let's make sure that community health workers are represented. One of the key points in this book is that representation is essential. If you are not a representative of a group, then you're an individual. And individuals matter, but groups are collections of individuals. And if we can have our community health workers working in primary healthcare come together as a constituency, that has to be recognized by governments, especially because of the key role that community health workers play in the health system. So as you see on the slide, the issue of legitimacy is very critical here. without that kind of representation, without government knowing that you are not there as just an individual, but you have the backing of thousands of other people who share a similar interest, you'll have a stronger voice with that kind of representation. And I think it's also very important that we don't have just a few people who step forward. We need to rotate the people who come forward. Make sure there's some level of continuity, but make sure there's people coming in and out. And government should be able to see, for instance, among your community health workers, they should see people from different genders, different tribes, different cadres of the health system. They should see people from different linguistic backgrounds and even different political affiliations. So they know that something unites us, something brings us together, and it's the issue we're bringing before you. Such as I mentioned, we need recognition as former health workers among community health workers. So this handbook, it's very much truly a handbook. It's telling government how to do things, because government it's very top-down and hierarchical. And if I'm a government officer, then I take my orders from above and I make sure I execute them properly so that I can escape the wrath of my bosses, because it's top-down hierarchy. And if we want social participation, we do not want me as a government officer taking that same approach with everybody who's seeking an ability to negotiate with the government. We need to set it up as equal footing. So that you see the point about a neutral facilitator. Make sure that there's somebody there who's taking power away from government and sharing it among all constituencies in the groups. Having homogeneous focus groups. That's because sometimes we want a diverse debate, but sometimes we need to spend time to think of and express our own ideas. And again, if we have a government officer who's present there, I may not feel comfortable saying what I think is most important that needs to come out, because I don't know how I'm going to be treated afterwards. If we come together as a group, we can build a constituency. And I see that as important, again, for community health workers. There's other points you can see about the location, the time, the preparatory materials. All of these are points that government needs to know, because government doesn't have a strong experience in working with its own people. They have very strong experience in working in hotel rooms with people who can pay for hotel rooms or conference rooms, but not necessarily with us in communities. All right, we talked about balancing power. And it's really this social participation, the principles of social participation are to bring those who have less power to those who have power and remove that power differential so we can talk as equals and get issues on the table. You can see over here, we're emphasizing in many different points, the quality of exchange, the level playing field. What does it take to make sure that these elements are put into place? And again, underlying that recognition. If you are there as a representative of a group, then you can be recognized. And if you are not representing a group, if you're not banding together, it's solidarity. We need to show that solidarity when we speak with governments, because one of the basic principles is that those in power find it easy to divide and rule. And so by uniting, by coming together, by expressing our interests as civil society or as community health workers or as frontline health workers, we get our strength by having that union together. Here, I mentioned in the earlier outline that government needs to know what to do with the idea of social engagement, social participation, and engaging with people. I'll emphasize again, we want this to be part and parcel of what government does. It's part of being in an open society. It's part of being in a democracy. And it's not simply that we have these civic freedoms. We have to be able to engage with those responsible for delivering on human rights. And that's the bottom line. If we can't do that, then we're going to have not just repression, but also a failed health system. And a failed health system is what we see since, especially during COVID. Much of what's happening during COVID is because our government has not prepared a fully responsive health system. So I would like to say, let's see, can we get our government people to understand that it's part of the goal is to be able to be interacting with and understanding perspectives from their CHWs, from their civil society groups and communities, and also then they can channel some of this information into specific uses. such as policy. Not always the priority, but it's something that government keeps in mind because that's part of their work. You can see the other point, it's emphasizing again, participation is a goal in and of itself. And then finally, how to institutionalize this. We talked a little bit before that government may want to see social participation as a one-off, as something that can be done for a specific purpose. And then, thank you very much, that was excellent. We'll see you again at another time. No, we want to make sure that social participation is something that's embedded in government processes, just as budgeting is. They don't work without a budget. They don't work without an annual work plan. They don't work without reporting to their superiors about what was achieved and what was not. They should not work without the same kind of engagement with the people whom they serve and with their frontline health workers. All right, taking the rights-based approach over here, the legal frameworks. So even when we have frameworks that allow for participation, how will a local government official, how will a hospital or a clinic manager understand what that means for their own work? Here we can provide examples, and there's much more that we in the People's Health Movement, the Health Workers for All Coalition, and among broader civil society can do to share about this. I'll say from PHM side, if you go to phmovement.org, we've just recently put up a series of case stories. Many of the ones from Southern Africa deal directly with community health workers and how community health workers have responded to the challenges under COVID. These are important case stories. I'm bringing it out right now outside of the handbook because the handbook doesn't address examples. It's a how-to manual for government. But these examples are things that we in civil society can bring so that we can help government understand this really does happen and here's how. All right, so the other point that's very strong to make is that having these legal frameworks is helpful, but it's not everything. When they exist, they can be ignored. And when they don't exist, it doesn't stop social participation. There's nothing in any government that stops people from expressing themselves to their political representatives or to their civil service, including the health sector. So again, if we are coming together as community health workers, what can we do to band together so that we can express certain ideas, interests, needs to those people who actually manage the budgets, who allocate resources, who make purchases, and then make decisions about how those will be used. I think those are areas that we don't need to have a clause in the Constitution to cite. If it's there, that's fantastic. If it's not there, or if we don't know about it, that's not a barrier. This is something that we can move ahead with. Coming to the end, this is chapter 7 now. How do we carry things forward? Once we have let's say a brief series to kick off social participation. It could be again around UHC, it could be around primary healthcare, it could be around PPEs for our community health workers. There's any number of issues that once we have government's attention, then we need to keep that attention. And how do we institutionalize that? This chapter talks to government about what they need to do so that they can maintain this and why it is important for government. So a lot of this is really just making sure that there is that long-term sustainability. It's making sure that's embedded in annual work plans. It can be done on a quarterly basis. It can be done on a monthly basis. The point that's missing here is that we in the community health workers, we in civil society are often doing this out of our own passion and goodwill, but we are not funded to do it. And let's face it, those in power, whether government or otherwise, they have resources that they can spend their time on this and not be making a sacrifice. I think it's a limitation right now that we don't yet have a recognition about how community health workers can sustain their own engagement with government, even if government is ready to sustain it for them. I would say that that is another agenda point for community health workers to be able to come forward to government and say, we can have a productive relationship. We have achieved X, Y, and Z in our first few meetings. For this to become something that you can rely on, that you can ease your work in government, here's what's required to make sure that we as community health workers can be there. And I see that as a real point that goes forward for the instance of social participation in the context of community health workers. So I'm coming to the end of my presentation. I know I've been trying to keep things a bit short just so we have time to speak. Number one, as community health workers working in primary healthcare, yes, we can use this handbook. It's useful because we can take it to government. We can show government this is how it's done. And this is not us making it up. This is coming from an established, recognized health authority, WHO. But next, and I've said this several times throughout the chapter reviews, it underlines the need for community health workers to be recognized as a constituency, must be organized in order to be recognized. It can be a union. It doesn't have to be a union. It can be an ad hoc collective, but just showing the power in numbers and the unity, the solidarity that brings everybody together, that's essential. And then finally, the handbook is a starting point. Let's not see it as the full picture. Let's keep in mind that this is, in some ways, the recommended minimum for governments to do. I'll close right now, and I just want to say one more thing. The handbook is very much, it came from a technical perspective. It's a how-to manual for government. There's the political dimension that still has to be addressed. And that means, does government really understand that health is not simply a technical solution, the way it's taught in medical schools? The political dimension to health is, do we recognize who has power and who doesn't? Who suffers because of their position in the power structure in society? And that's part of the political determinants of health. But again, for the health workforce, how can community health workers have a stronger voice in supporting a strong health system? And especially now in COVID, when it's recognized that health systems across the world are not fit for purpose, they're not delivering, and it's not because of the people, it's because we don't have the people, enough people, and we haven't given the right equipment and voice. So Shabir, with that, let me pause. I'm happy to take a few questions, and I've seen that there's quite a bit on the chat also. So as you facilitate, I'll be checking on the chat and seeing what I can come back and address to
That'd
others.
be great. Well, thank you very much, Ravi. We're fortunate in having the AfroPHC president, Dr. Innocent Besige here, and also Dr. Ms. Francois Wabufo, who are going to make comments shortly. So perhaps I can ask Innocent if you could just make some comments in response. There are no questions, either comment or questions. And I think, Ravi, if you have a look, there are some comments from Danny and maybe some questions, and you could respond to that. Yeah, Innocent, do you want to make a few comments before we move on to the community health workers and perhaps respond to some of the questions?
Yeah, thank you very much, Shabil. Once again, I'm Innocent Besige, the president of AfroPHC. I am seated here at Makerere University in Kampala. And on behalf of AfroPHC, a warm welcome to everyone who attended this workshop. And thank you, Ravi. The comment I wanted to make, your conclusion says it all. I think you were quite loud and clear, and probably that is why you don't have so many questions. And really what you are talking about is a clear clear concept that we all know, that there is a lot of evidence from all around the world on the importance and the role of community health workers in improving and strengthening health systems. And I think in most of our countries, community health workers really form the base, they form the foundation of the health systems because they are based in the communities. And I think what you have, your summary of the handbook really is a concise description of how governments should be operating and the policymakers. And I think our duty as people who are really interested in improving the health of populations and the communities, particularly through advocating for community health workers, is really to embrace what you're talking about and what is in the handbook, so that we hold our governments accountable. It's quite common for governments to pledge political commitment, but what normally lacks is political action. And I think, as you have rightly said, the power of numbers. We can really use the power of numbers to now start drumming up for political action being translated, political will being translated into political action. And I think once we do that, we now have the starting point. And together, if we keep maintaining our vision and moving and looking into the same direction, I think we shall really be able to achieve what we desire. And I think you can notice that what you are talking about, there are so many people who are already converted to trying to see how community health workers can better get organized to deliver the required community health services. By just looking at the participation of this workshop, you can actually tell that at least to have the bare minimum number of people from at least the African continent, and actually I've just scanned through from all over the rest of the world, that you really have a big voice that can make things happen. Thank you very much once again, and I really thank you on my own behalf and on behalf of the AfroPHC and all of the participants for really this clear and concise presentation. Thank you, and I wish everyone fruitful deliberation. Thank you.
Ravi, any response to the comments? I think you just thanked Danny for the comments, but I don't know if you have any comments to that comment, and I could just ask one or two questions.
Sure, yes. First, many thanks, Innocent. I fully agree with you. And I do believe that in Uganda, at least, you're farther ahead than we are in Kenya in terms of recognizing the role for community health workers. And that pleases me quite a bit. We need to have these kinds of examples from within our region. We can't just be looking elsewhere. And having you across the border is a huge strength. I do think that the political issues is the biggest one. And so that this handbook is a way of easing the political minds into seeing this as a technical issue so that they can feel comfortable. But in the end, it's the biggest one is the political questions. Can we be recognized as a role in health workers? I'm going to pick on Danny's question. I just started my response, but he was wondering about the point that many policymakers or government officials are saying that we have to choose between community health workers and nurses and midwives. And how do we do that with limited resources? I think the proper response is both political and technical. It has to be both. What the 2020 proved to us is that we don't have the skilled health workforce in the numbers that we need. And if it's a question of this versus that, that's the wrong question. The real question is, what are we going to not spend our money on so that we can have both nurses, midwives, as well as community health workers? And I think that's the kind of response that we should say, and not say, well, WHO's technical advice is this many health workers for that many population, because in the end, we'll be shortchanged no matter what. The real answer has to be we need a fully functioning health system staffed properly, especially at the front line.
Well, thanks, Ravi. In fact, Ravi, just a quick comment, and I know you've got to leave and we've got to move on a little bit soon, but in terms of AfroPHC, we have this session precisely because there was a strong call in our beginning sessions about the need as a primary health care team to include community health workers and to have very strong community engagement participation. So that's the values around this collective of AfroPHC as a range of healthcare workers. And in fact, we've moved away from just simply talking about healthcare workers, but the primary healthcare team, which might include not formal health workers as well, and even community representatives. I think it's a question of, like you said, not either or. And there's good rationale for community health workers. And where I work in Shewelo in Soweto, I've been trying to show the value of a strong community-oriented primary care approach, which includes community health workers that are able to work with the team and be able to improve healthcare in the community as a part of the collaborative, and that's called community-oriented primary care. And we treat it as family medicine to our clinicians, and I think this is these are the values we'd like to share with other members of the primary healthcare team that see community or primary care as a part of their clinical practice. And one of our challenges has been in that the implementation of community health workers in South Africa, as an example, has great value, but in some way there are big problems with it, where because of the payment of community health workers, we need to know that, yes, there needs to be payment. So it's not saying no payment, but the payment tends to create a cadre that feels more obligated to the payer than the community. And so many a times, even community clinic committees tend to become extensions of the health service and tend to try to protect the health service rather than protect communities. So I think there's a big dynamic problem. Even engaging communities can be very challenging. It's very easy, like you pointed out, for it to be captured by elites. Often, because those political processes, if they're not very strong, they tend to become captured by elites anyway. So I think that's some of the challenges which we have to do. And one of the key things that I think very important as a value in our group is to say that primary health care workers on the ground, and I'm talking about the full spectrum from doctor to community health worker, need to embody these values of community participation and to actually turn it on its head to prevent the health system from trying to undermine communities and in fact using this kind of approach to strengthen itself against bureaucrats and give communities the voices that they can in fact assert themselves. So I think our idea is to try and build PHC teamwork more broadly and provide good clinical supervision and support, but also help empower. And I think that's a key problem that we need to think about. Mm-hmm. So just a comment, I'm not sure your thoughts, but just to share that view.
I like the way you put that, Shabir, because you're saying it's not just, it's both the clinical oversight, the technical side, as well as the empowerment. And so that's putting the technical and political together as part of the answer. They have to be hand in hand. And I'm seeing it on the chat, Alice Hazemba from Zambia. She's also pointing out the same kind of thing where the incentive, once a community health worker or community health agent is recognized as part of the health system, their individual incentive is to move up within that system. Right. And I think that's very much reflective of government being hierarchical and top down, where the only way to have a voice is to move up. The more we can do that, the more we can change that so that we have people who, the frontline health workers, have a strong voice, the better. This handbook is not the be-all, end-all solution. It is a part of the solution. And it's only a part of the solution to the extent that we can shape it so that government is able to listen a little bit more closely to what we're saying. That's why I've been emphasizing that let's see it as a starting point for our work with government. It's just capturing best practices and putting it out there, and let's call it the baseline. There are a few other points over here. I do need I want to cover things, and I also want to open up so that we can have further discussion. Kiande from Kenya is also saying, employing the bottom-up approach to get buy-in from various counties. Counties are our decentralized administrative unit here in Kenya. And there's also competition between the counties and the central government over who controls the health system. Under the Constitution, it should be the counties, but because there's so much money in the health sector, the central government is reluctant to let go. And I think, yes, there's the strategy dialogue needs to start. I think what you're also pointing out is that we need to have multiple constituencies. This also gets to your point, Shabir. If we have community health workers backed up by community representatives, and they've spoken in the background, that's quite good. And let's not say that it's a purely altruistic or idealistic dialogue. We know that many in the community will be jealous that somebody has been appointed as a community health worker, and then they have a certain status, they have access to resources. Even as being a community health worker, you feel that you're not actually being supported by your health system. So there are all of those dynamics, and that's just the reality of we are easily divided by those in power. And let's keep that in mind. That's coming back to the point that Danny outlined in his question too. We should do all we can to work to make sure that we are united among our constituencies so that we can talk to government and get something that meets all of our needs. Our needs may be technical, but our approach has to be political.
Great. And I think we'd really appreciate you being able to assist us in terms, and I think we hope that all of the people participating will help AfroPHC bringing in community health workers and that constituency into this group to be engaged in all the discussion that we have around primary health care and to be an active part of this kind of THC teamwork across Africa.
Thanks so much, Shabir. I'm looking forward to hearing from the other speakers. I'll close right now.
I don't know if we haven't had any questions and comments apart from that. So let's perhaps move to the other participants. And we are fortunate in having, I think, 3 people, but I think the third person might have challenges. We'll have to try and link him up on WhatsApp. So let's just see if we can get somewhere with that. So the participants, let's see, just see quickly. We've got Danny Gotto and Mary Mulenga. Danny is a UHC activist with PHM Uganda. He's a founder of Innovations for Development, I4DEV, a hybrid NGO delivering last mile PHC in poor, underserved urban communities in Kampala. He works with community health workers to deliver healthcare using home-based care package that complements the community microclinic model. He's a doctor with an MPH MBA, 17 years working in lots of different places in Uganda, Rwanda, and DRC. So let's welcome Danny. And then I think we'll move across to the next speaker, Mary Mulenga, who's 48, working as a volunteer at Buchi Main Clinic for 29 years. That's in the Copperbelt province in Ndola in Zambia. She's received training as a psychosocial and adherence counselor, a community-based distributor of family planning, a cervical cancer peer educator, and respect maternity care. She works tirelessly as a volunteer, and we're really pleased to have her. So if you can unmute yourselves and just join the conversation. Mary, if you are here, I'm not sure that we've been able to get you here. I think you are. So if you can unmute and go ahead. So great to have you. So we'll have some comments by our Deputy President of AfroPHC afterwards. But Danny, some comments. Do you want to share your experiences as working with community health workers, and specifically to answer the question, how do we support community health workers to be part of the primary health care team in Africa? And I think, you know, some advice to us as a group of AfroPHC. Thanks, Danny.
Thank you, Shabir, for first of all the invitation and the platform to share my experience working with community health workers from the Ugandan perspective, and indeed DRC, particularly Goma areas and parts of Rwanda. I must say, reflecting from what Ravi has just shared, and indeed an amazing blueprint that can guide the conversation. But one of the things that community health workers have been saying over the years up to now is recognition. They need to be recognized. And of course, recognition is interpreted in many ways by different circles and governments and civil society. For instance, in Uganda, they're still, taken as any community volunteers. Now, the mistake that we're making as advocates is to universalize community health workers. The contexts are different. I know the conversation that happened just a minute ago, some say we need to incentivize them with a pay. Others, no, we don't need, let them remain volunteers because they are part of the communities. But my conversation with community health workers, up to today, they're telling me, some of us join community health work because it's the only alternative available for us to contribute to our society. So, or others, they are young people who simply are waiting for opportunities to come their way and they are giving. Maybe they need to see themselves progressing in the hierarchy of the health system. So we must not close it. If there are opportunities that the system can allow a community health worker, for instance, becoming a community nurse or a midwife or whatever, that must be supported. Then they are also talking about the aspect of incentives. The question in Uganda has created a lot of space in Uganda is dominated by non-profits, NGOs, particularly international NGOs, that of course remunerate, some pay, some give t-shirts, bicycles and whatever, and there's no consistency. Sometimes there is no coordination on who gives what. This one gives more than this one. In the same community, one who is working on reproductive health gets $10, another one working on HIV gets started just because one is funded by a bigger NGO, another one is working with a local NGO. So that disparities even within the space where they are working is something that they are saying must be improved. And that is something that we have control over. Then the aspect of training in the context of Uganda, and given the history of Uganda, the CHW program started with the HIV movement when we had an issue of epidemic of HIV in the late 90s and early 2000s. So it came from the communities organizing themselves to give back to their community to help the sick and give some sort of care. However, NGOs and a little bit of government hijacked the space because, of course, when the HIV funding started coming in, there was interest to create community movement to engage. Now, when funding came in the picture, the whole environment was distorted. So we need to reflect and see what are the things that we're doing as civil society, as activists, as government that are inflicting pain and struggles and not recognizing the struggles of community health workers. So they are saying, if we don't want to, if NGOs or activists do not want us to be incentivized, then they should also come to communities and work for free. As after all, we are all working for the same people. But how come they get paid, we don't get paid, and we're expected to deliver quality care? Then you see in Uganda, it is where you find each sector, because of the strength in mass of finance, is working with its own community health workers. This NGO, international NGO, is working with them for maternal health. This one is working for them on nutrition. There is no consolidation of a package. And each one rewards differently, each one trains differently, each one monitors differently. And that's the conversation that the nurses and midwives have expressed to me and saying, it seems, and Rabi mentioned that we need to be cognizant of the divisions and now not to fracture ourselves more. But they are saying that sometimes in our work, when we overemphasize community health workers, we are silent on the plight of midwives and nurses. So we also need to be cognizant of the issues, and then we collectively say, yes, the health system, yes, we are advancing community health workers, but we also look at the nurses and midwives who are at the bottom, struggling for recognition, struggling for better pay, struggling for having the right tools to use to deliver their services to the communities. So I think that is also a conversation that we also must never forget. And lastly, I need to mention the manual talks about a blueprint on how we can use to engage. But in Uganda, we are seeing, of course, the politics winning the day. I am reflecting on the last many years we have been advocating and championing, and then one step forward, 3 steps backward. I think my worry now is, yes, it is important, but the politicians still have a very big stake in, first of all, getting convinced that what we are talking of is important, but also recognizing now that COVID has come, that as I speak now, most people are stuck in their homes. The healthcare system is choked up with many people whom they cannot even receive. Now, community health workers are coming up to be able to give something, but they are not prepared. They were not involved in the COVID response in the early days, and now we are all stuck. So this is an opportunity to show government that, you see, if you had proactively engaged community health workers, channeled the right information and training and capacity building, probably they would be now coming in to support you where the healthcare system has, of course, failed as I speak of now.
No, thank you very much. I think those are very thoughtful remarks. And We'll come back to that just now. Let's just move to Mary, and then Tiamike fortunately has joined our call. We'll get him to speak just now. So Mary, your thoughts on your experience as a community health worker, and how can this collective, AfroPHC and primary health care teams in Africa, support the inclusion of community health workers in the primary health care team? So your thoughts, Mary?
Yes, good afternoon. My comments are, as community health workers, we are less privileged. Even we are the link. We are the link, the community and the facility to the community. You see, now I've worked 28 years, more than 28 years. I've got experience. We are doing counseling. We are doing counseling, testing and counseling in the community as well as at the facility. The training, the counseling is a dialogue between a trained counselor and the client. So as you can see, I said we are, as community health workers, we are the link to the facility and to the community. In maternal health, you can see that we community health workers, we are the first one to go and recognize the person who is pregnant, bringing that client to the facility, continue monitoring that client until the mother gets give birth, and the mother until the child is 5 years. So there's a lot of work we are doing in the community. And in community growth monitoring and promotion, we are also doing monitoring in the community. So we are very important in this issue. If the government can still look upon us and see what the way forward, what they can do about us.
No, thank you. So, Mary, and just to sort of summarize, I think what Danny has basically said is that, you know, the community health workers need to be paid, they need recognition, and that the politics needs to be managed. I think what you're saying is, Mary, is that, you know, the community health worker serves a very important link to the community, between clinic and community, and that there's some really useful work that's needed. And I think that you need to be formalized and supported. And I think that is something that everyone agrees with. Tiamike, you have you joined us. Thank you very much. Unfortunately, you haven't shared, you know, details of your background, Tiamike Goliati. Do you mind just sharing a little bit about yourself and just responding to the question, how can we support AfroPHC, support the inclusion of community health workers in the primary health care team? Tiamike, are you able to unmute yourself? Okay, it seems he's slightly challenged. He did have a problem with his internet. I'm not sure if there are any comments from anybody or any questions. So perhaps while we wait for Tiamike, if he can get together, we can do that. Can I ask Francoise, our Deputy President of AfroPHC, to make some comments in response to the comments that have been made? Francoise? Is Francois with us?
Yeah, thank you very much.
Yes, go ahead, Francoise. All right.
Good morning, everyone.
Welcome.
It's actually a very exciting topic, and we all acknowledge the role of community health workers in the team, in the full spectrum, being the full spectrum of the PHC team. And Danny and Mary have come up with real pertinent, where we can really see their commitment and their role in the remote community. They've come up with some real pertinent problems that is almost everywhere, and it's actually really a challenge knowing that from the same community, some are being paid. There are some NGOs or some associations that work with these community workers and just give them barely maybe transport money, while others come with some big incentives with t-shirts, like he's saying. It is really a problem in the community. But one other thing I would like to say is, as we absorb these community health workers in the AfroPHC team, I think we have a role in working with them so that the voice will be heard. What do I mean here? I mean the work we do with them should really be organized in such a way that whoever comes to such a community will recognize that this community is actually doing a lot, and the voice can quickly go through the action. And with that, the government will really see the need and the necessity of having a community health worker on the field. Here, I also mean in such an organization that, you know, this community health worker is taking care of this section, he brings this report, he does this, I'm involved in capacitating, I'm involved in this. So really fully engage them and immerse them. I think it is also the work of the AfroPHC, the primary healthcare team on the field. But another problem is that most of our primary healthcare are not even doing well on the field. And so the gap between these community health workers and the next health system is sometimes not really well organized. So I think there is a lot of work to do. I think there's a lot of work to do, but we can never neglect what is being done on the field as in terms of helping the population. They give many names to it, community health worker, community relay worker, but all I know is they do quite a lot of work on the field, and they really need to be recognized. Gradually, the CSOs are now entering fully into play. I think that it's time for us to help the community health workers to be fully recognized. Thank you. That's just some few reflections for now. I didn't want to go into what they already mentioned, which are real, yes, which are true about the payment, the recognition, etc. Recognition. So thank you for now. That's where I'll end, but it's really an exciting thing to ponder about. Thank you all for the great work you are doing in the community.
Thank you to Françoise, and I think she's a great. I mean, we all are great champions of community health workers activity. I just want to see if, in fact, we have an opportunity for Tiamike to unmute himself. If he's struggling, I think we'll break up into groups. We are going to talk for about 45 minutes, and it's groups for about 8-9. So I think it should be easy. One of the reasons we have these group discussions is so that you actually meet each other and I think share your own thoughts. I think the key question we're going to ask ourselves in groups, Tiamike still not available. So the key question in the groups is to be able to ask the question, how do we, as AfroPHC across Africa, as well as each of us in primary healthcare teams, how do we support community health workers and community participation in our primary healthcare team? So I'll just, we'll look at 45 minutes. I'll send you some reminders, but if you can, amongst yourselves, just nominate someone that will be able to facilitate and somebody who'd be able to take some notes. We really do want those notes back. If you can just put it on the chat or email it to me, I'll put my email down later. If you can write it as a document, I think we want to capture this and include this in documents as we're going along. Let me just see if Tiamike, are you able to unmute yourself? I'll just give him one more call and let's see if he's able to speak. Hi, Tiamike. Are you able to speak? Okay, I think he's challenged. So I just want to share quickly his bio, so at least we just know he's been part of this. Tiamike Harold Gigliati is the Executive Director of the Coalition for Health Workers, HRS Plus, and he's been working as Operations Director of Research and Business Consult Limited. He's been a health and nutrition program manager for Africa, Malawi, a chief programs officer of maternal health and safe motherhood in the office of the President and Cabinet of the Republic of Malawi. He's also a nurse educator lecturer for Malawi College of Health Scientists, a paramedical team supervisor for MSF, and a pediatric ward in charge. So it's a real pity we couldn't get him to speak and share his thoughts. Perhaps we can try when we come back for feedback. We'll come back and in 45 minutes. So thank you all and enjoy. And just click on the join and join in the breakout room. And please use the opportunity to nominate a facilitator. I think we have got members of the board in there. So let's hope they take responsibility. Thanks. If you're still in this room, I will allocate you. Hi there, are you okay? Hi, Tiamike. Hi. Can you hear me? So Tiamike, we are going to have to arrange for you to join, to speak briefly afterwards. Is that all right? I couldn't get you through. Hello, Tiamike. Just thought I'd tell you we had to break. It's challenged. I think your internet's challenged. What I suggest you do is don't use your video, and we'll have to come back and after 45 minutes. Hi, everyone. Welcome back.
Hello.
Hi, everyone. Welcome back. Great to have you all back. I hope the discussion has been very useful. Tiamike, I'm not sure that you can unmute yourself. Are you able to speak, Tiamike? You've unmuted yourself.
Yes.
Great, great.
Hello. Are you able to hear me?
Yes, yes. Thanks you, Tiamike, for you being able to share some thoughts. We have already announced that you have a lot of things to your name as Executive Director of the Coalition for Health Workers. We'd really appreciate your comments on how the AfroPHC could support community health workers to be part of the primary health care team in Africa. Tiamike, go ahead. If you can spend about 5 or 10 minutes and just give us some thoughts, and then we'll try and get representatives of each of the 4 groups to just share briefly their discussions. Go ahead, Tiamike.
Okay. Thank you very much for joining me to this group. Yes, community health workers could be a solution to most challenges, health challenges we are facing in Africa, in line with the primary health care. Considering that most of the community health workers are rural-based, and they are recruited based on the project that is coming in that area. And they are just incentivized by a certain amount of money on a monthly basis. And once that project is over, their roles stop right away there. Now we are saying, for example, in Malawi, we over 10 years ago, we as a country we had a lot of deaths among pregnant and women in labor. So that to address that high maternal deaths that was facing the country, the studies that were conducted discovered that one of the contributing factors to higher maternal deaths was the use of untrained community health workers, known as traditional birth attendants. But due to shortage of healthcare workers, mostly pregnant women were going to these traditional birth attendants to deliver them, because they had no option. Once they go to the health facilities, they could find very few or no health workers, nurses and midwives who could help them. But the nearest to them could be the villages, that is the traditional birth attendants. So government then decided to ban the delivery, the home deliveries by these traditional birth attendants who have been doing their work for over many years, and they were paid by clients themselves once they get those services. Now, when the government banned these ones, they tried to introduce a new cadre similar to that, but trained professionally in the midwifery colleges. So they recruited young women with qualifications equivalent to O-level. Here in Malawi, we call it MSCE, which is equivalent to O-level. And they were recruited straight from the village with the assistance of traditional leaders, so that to address issues of bad attitudes and others. And once they were trained, they were recruited, we were picking them, because I was also part of that team, considering that at one point in time I was coordinating that program in the office of the President and Cabinet, specifically the Safe Motherhood Initiative Department. So when we recruited these ones, and we were sending them into colleges, by that time the curriculum was developed, and then the syllabus was also in place. And these ones were trained for 18 months. And after the 18 months training, the Nurses and Midwives Council licensed them through the exams which these community midwifery assistants were subjected to write. And once they passed, and those ones that passed, they were recruited formally into the formal employment, but allocated in rural health centers. Of course, by design, they were supposed to be in specific villages, especially in the villages where they are coming from, with equipment that could help them to provide maternal and maternal health and neonatal health, child health, as well as other services. So the training was quite rich that could enable them to do the work, even including the deliveries of these women, but maybe targeting low-risk pregnant women. But due to shortage of healthcare workers in Malawi, nurses and midwives in particular, these community midwifery assistants, which are part of the community health workers, have been allocated in rural health centers. And in most of the times, you could find them alone. Of course, by design, they are supposed to be supervised by seniors. But due to shortage of healthcare workers, sometimes they have no choice but to attend to pregnant women. Lucky enough, they are doing a good work. They are paid monthly, and at the end of the day, they are getting everything, all the benefits, like any other civil servant. And we did an analysis of one facility. We targeted that, we looked at the deliveries conducted by 4 professionals at that particular, including these community midwifery assistants. Out over 300 deliveries that were conducted in that facility over a period of 3 months, over a period of about 5 months. Over 50% of deliveries were conducted by these community midwifery assistants. And they did those deliveries without any assistance. Because of the shortage, they could be alone in, that, in those rural health centers and be conducting the deliveries. And lucky enough, during that 5 month period of our analysis as a coalition for health workers, we did on those community health workers, specifically these community midwifery assistants, we discovered that there was no death, no maternal death that was incurred. And at the same time, even we also compared the referrals that were conducted, that were done by other healthcare workers at that rural health centers. It was almost similar to these referrals that were done by these community health workers. What am I trying to emphasize here is that if we invest heavily in the community health workers by giving them professional training and then give them the monthly salary, but be based in those community health workers, they have the potential to address most of the challenges which Africa is facing. As we have seen, as an example, we have seen in Malawi, whereby now the maternal death is going down. The maternal ratio is going down. Now it's at about 439. But before that, it was close to 1,000 deaths per 100,000 live births. So you could see investing in community health workers by making them go through professional training, but allocating them back to the rural settings with enough resources, like what has been done by Malawi. We stand a better chance of winning the battle in our fight against various health challenges. And these community midwifery assistants are also even supporting HIV and AIDS management initiatives. Sometimes they provide antiretroviral therapy, antiretroviral drugs to HIV positive pregnant women. They also provide other services. So what I'm trying to say here is that if we are to do better in the primary health care, we need to invest more in health care, in community health care, community health workers. And interestingly, these community health workers are part of our membership. That's why we are able to follow and give a good analysis of their work. And this could be replicated in other regions. For example, Malawi has this well-developed syllabus for training of this community midwifery. And they are recognized by the professional bodies, regulatory bodies, Nurses and Midwives Council. We can do the same. Maybe in other countries, I don't know, there are some maybe overarching regulatory bodies whereby they can be trained and be regulated at that level, as the case of Malawi. And we have another cadre here, which is doing also a very good work. We call them, previously we were calling them health surveillance assistants. They were just recruited with an O-level certificate straight from the village without any training. But once they are recruited, they were they could do in-service training, on-the-job training for over 12 weeks or so. And once after finishing that training, they could be allocated to a specific village and be providing under 5 services. And now, because of the extreme shortage of healthcare workers in Malawi, there are some tasks that have been shifted to them, and they're also doing those tasks like malaria and other things, malaria treatment and other services. They are doing that. So what we are saying, community health workers remain the solution to most of the challenges we are facing in line with the primary health care in Africa and in Malawi in particular. So Malawi has done it, is doing it, and if we model that approach which Malawi used in addressing maternal health in Malawi, I think we can achieve a lot in addressing other health workers. I mean, other health challenges being faced in other parts of the world, or Africa in particular.
No, thank you, Chiameke. I think that's been very useful. I think Euphemia and I'm sure others would like to get some documentation. If you don't mind emailing it to me, we can put it on the webpage. Details of the Malawian model as well as the curriculum you used to prepare them. There's a very interesting question that Sunanda Ray asks. Do they actually function in the community as community health workers, as people understand it, or are they kind of more like nurses trained in some respects in that path? Do you want to just share what you think of that question, Chiameke? Do you still consider them community health workers? Do you still see them as community health workers, or are they not more like nurses with 18 months of training?
Actually, they are based in, by design, they are supposed to be based in rural facility. They are supposed to be based in villages, actually. Okay, but we see all the equipment, necessary equipment to do their work properly. But because there isn't such design at the moment, but they have done the training, so they have been allocated to health centers that are in the rural areas, and they're doing work similar to that of in fact, they're doing midwifery work, and they're doing the deliveries of pregnant women with the low risks, and those that have complicated that they have some complicated condition, they are referred to a higher level. For example, maybe at the secondary level, as in Malawi, we have primary level of healthcare whereby we have these health centers, and then in secondary level we have community and community hospitals and district hospitals. and then in central hospitals at tertiary level. So once they are faced, once they are faced with the complicated condition, they refer that from their primary level at the rural health center where they are based to another level, probably at the district hospital or thereabout. But actually, at the moment, they are working as a part of midwifery team at the rural health centers. This is due to shortage of those midwives. Yeah. And lucky enough, these ones are licensed by National Midwives Council of Malawi, and they are being monitored. And if they do the mistakes, they are
held accountable.
They are treated accordingly to that misconduct. So, but they are categorized as hello. They are categorized as part of community health workers, and they are supposed to be in the rural in the rural areas, specifically in the villages. But due to lack of settings, that as the area design, they are located in these rural health centers, doing the work of midwives, but at the rural level, and at the same time providing other services, nursing services, under 5 services, and also even providing HIV and AIDS services, like providing ARTs to HIV positive pregnant women. So, yeah, they're doing a good work. But
no, I think it certainly looks, Tiamike, very, very good. And I think it certainly suits your circumstance, I imagine, in producing the result. I think, you know, in Africa, there's so much of variety. So the questions are more related to trying to understand exactly how they fit into the overall system. There's a question which, you know, Euphemia asks again is, do they actually are they more facility, like what percentage of time do they spend in the facility as opposed to in the home of, you know, of the communities? If you were to just judge approximately, so that one has a sense of where their work lies.
Okay, can you come again? Can you come again, please?
What percentage of time do they spend doing work in a facility like the primary health care facility versus actually doing home visits and being in the community, home, and other spaces of the community?
In fact, it depends on their stage of work. Okay. Because at one time, at a certain time, they're supposed to do home visits. And at the same time, they're also supposed to be at the facility. So we cannot specifically say maybe a certain percentage, maybe let's say 10% or 5 to 15% of their time in a month or in a week is allocated for home visits. No, we cannot say that, because sometimes, you know, they are the ones that are manning these rural facilities. So they could hardly have time to go into the homes and visit them. And at the same time, even the environment itself is not by design itself. It is not by initial design, whereby they could go into the village and assess the pregnant women, do under 5, whatever. They do all those assignments at the facility, and they're staying at that facility. Of course, those facilities are within the rural settings.
Of course, yes.
Sure.
No, that sounds very clear. I think I think people would appreciate that details on the model as well as the curriculum. So, Mr. Tiamike, if you don't mind emailing it to me, and we can put it up and give people that. Thank you very much, Tiamike.
Yes.
It's been really great. Great having you speak.
Yes, I think I can come up with a write-up of 2 to 3 pages of this model here of community midwifery assistant training, and with some background information in how we've evolved from the traditional model, from the banning period up to the current situation we are in, whereby we have these community health workers being trained and being allocated to these rural health centers. I can have a write-up, and also I can have also maybe a brief a brief analysis of a certain facility, of one facility, targeting at least 4 professionals to do looking at their services they have done in relation to especially their roles in those areas and those facilities. So I think I can give that right up from the perspective of Coalition for Health Workers, and then be sent to you. And
sounds wonderful.
I'll do that.
Thank you for all the good work you're doing, and I think it's been really helpful. So I'll wait for you to give me that, and then we'll put it up on the website. Same with the recordings for this whole proceedings and any other presentations, etc. So let's perhaps go to the groups and just get some feedback very briefly. I think if we can just get feedback from group 1. I know that Francoise, you can perhaps give some comment from the group. And then if the other groups, if they can just pick up their hand, if they can just give us some feedback briefly, that would be really great. And please, if you don't mind just writing some notes, email it to me or put it on the chat. It would really be important to get that feedback so that we can incorporate it into a document that we're developing for WHO. Go ahead, Francoise. Yes.
Thank you, Francoise from Group 1. We had an exciting discussion around the CHWs, and we came up with some few points, being that they should be formalized, recognized. There should be job description, and then they should have a registry. We can identify every community worker working in the community, both those that have remuneration or not. And sometimes to get some of these recognized, we also need to work with some of the CSOs or associations that use some of these community health workers, so we can really get a full registry of who is a community health worker, who is working, and which area they are covering and which aspect they are covering. So some work has to be done in that area. And then some training will be brought to them, and organizing them. And when we train them, we need to describe what exactly would they be doing on the field, the job description. And we also saw that it's very important to recognize them. We've said largely that recognizing them is one of the things they really reclaim. And so we try to make sure they are being recognized for the great job they are doing on the field. We also spoke about motivation and some incentives, which may not only be fund money, but even some addressing some certificates of recognition, what they are doing. And we also had some people share how far they've gone with some community health workers. They have even using Android phones on the field, which can really denote how many kilometers they've made. Meanwhile, there are some that do not have these resources, and how do you handle them? So we need to identify whoever is working on the field and what the person is doing. And then we also went further to say that the primary healthcare team have a great role to make their voice being heard. And if we empower them correctly and follow them up, it's going to be a great team, because some of them really come back with data from the field, and in some communities those data are not being used. They're just piled up there because it's not well structured. Meanwhile, those data can be translated into reports, into intervention. You can plan activities, and then it can even be carried out as research. But all these data are not being exploited because it's not well organized and not well coordinated. So those are some of the points we came up with. And then we also say in every community there should be a team leader who reports. So if they are well organized, we have a team leader. The team leader knows who covers which community, how many houses, how many kilometers does the person go. You can really keep a track of their work, and then bring up some principles and follow them correctly on the field. Thank you. Those are some of the points we came up with in our group.
Very useful. I think a lot of it echoes what has been spoken about before, so it's really great. Elizabeth, are you going to be able to share some of those thoughts briefly? But thank you for putting that in the group. Elizabeth, are you part of the same group or another group? Do you mind just Elizabeth?
I'm part of group 1.
Part of the group. All right.
So,
no,
yeah.
Thank you very much. Appreciate that. Is there anybody from group 2? I know Mbali, you are part of group 2. Just briefly, what you'll discuss, what you found significant, especially if there were, you can just mention that there were these similar things, but if there was anything different, you can elaborate. Mbali, perhaps you can from the group with Heather and Michael and Tiamike. Do you mind sharing it quickly, something? I know you've got some really useful comments, Mbali. In the meanwhile, I think Cynthia, your group, if Sanele, I know you're facilitating, if you can just share quickly some thoughts. And then the last group, I think Nontlantla, you had some very useful comments as well. I think you're suggesting, all right, sorry, you're leaving just now. But Alice, then Hazembe, any comments from the groups? I think we'd be sad if we didn't get that kind of feedback. It's not captured, and we would not know what happened in those discussions. So please, if you don't mind, just sharing it briefly.
Okay, can I come in, Prof. Musai?
Yes, go ahead, Sanele. I think whatever we can get, we don't want to close without making sure we've got as much of the views as possible. Go ahead, Sanele.
Okay, I'll just drop 2 points that were not mentioned. The issue of the role that AfroPHC can play in the formalization of community healthcare workers is that AfroPHC can lobby and play an advocacy role for community healthcare workers so that there's buy-in at the different levels of government that are at implementation level. The levels of government that are important in making sure that community healthcare workers are integrated into our primary healthcare system. The second one relates to that of remuneration, whereby we said that it is important that community healthcare workers are involved, are included in the structures, in the organizational design and development of organograms. So that, especially as we are planning for NHI developing our structures, it's important that they are included there to make sure that their remuneration is well structured. And it was also raised around training that we need to have continuous training of community healthcare workers, especially because we are now online and there's regular development, new development in terms of the conditions that arise and the changes really in the landscape, in the disease landscape. So it's important that there's continuous training of community healthcare workers. So those are some of the points that came out from our group.
Wonderful. Thank you very much, Sanele. Appreciate that. Is there any other group? I think, I certainly think that teamwork is really utterly important, and the way in which we might lobby as AfroPHC, I think those are great ideas. And how we can actually structure them as part of the, our thinking overall as a PHC team. And I think training has been very helpful. Thanks, Sanele. Any other groups that can please share some of their thinking? If you are not going to share that, it'd be a terrible pity that your discussions haven't been noted somewhere. Anybody else before we stop?
We had
yes,
Danny.
Yes, go ahead, Alice. Thank you.
No, we had Danny to present for our group.
Right.
I don't see him.
I think he might have left, but if you don't mind, just briefly, what were the key points that you all kind of came up with? Or is it mostly what we talked about? Was there anything different?
Yeah, most of the points I think are similar, but just to mention that there was the thinking that we need to reflect on how far back do we come with voluntary work in Africa, for example. And while we are thinking of that, how then can we structure the community work in such a way that it stays in the community and is sustained at community level? There was also a discomfort in thinking that many a times, because of funding that comes, it changes the complexion of the whole thing of community voluntary work. but also recognizing that when people invest time in voluntary work, they need to be appreciated in a way. So empowering communities to have funding that should continuously or sustain support of community health workers, that is the only way it can be sustained at community level. However, we did not also think that not paying them is the right thing. The important thing is they need to be reimbursed in one way or the other.
No, absolutely right. I think that the community orientation challenge is not of just community health workers, it's of all of us, all of the healthcare workers. We are not trained to be strongly community oriented, and we also are just as bad as the bureaucrats above us in the way we relate to communities. So we all need training to be engaging and supporting communities, even community health workers. That's the tension we all have. Sunanda, thank you. You want to comment? If you can just unmute yourself and comment. Yes, go ahead.
Yeah, thanks very much. I just wanted to, just responding a bit to what's in the chat group and also what was in our group 4, with Innocent Besege and Alice Hazema. I think this issue that this shouldn't be an excuse for less investment in healthcare in countries. True. And I think sometimes it's been an excuse. We give, it's mainly women, but sometimes it's also men, but you give them a small stipend and you expect them to carry a huge burden of connecting with the community and carrying out primary health care. And the issue about ownership, is it owned by the community or not? And Danny and I were remembering that this concept of the 10 households, that the Mozambique model in the 80s, and apparently Uganda also had this model where each community health worker only looked after 10 households, but did everything in primary health care for the 10 households. So advised on water and sanitation, childhood vaccination, made sure women went for the whole range of things, but for a small catchment area, which meant that they didn't spend a lot of time traveling, and they knew the families very well, so that sort of brigadier concept was more workable than what we're expecting community health workers to do now. But wherever it's used as an excuse for not putting the correct funding into primary health care, it's not acceptable. So the advocacy role of continuing to push for a decent health budget, which encompasses the whole range of activities in an integrated way, that really still has to be at the forefront. And I think somebody said, wouldn't it be better to invest in trained midwives? There's also the reality that as soon as, in our situation, as soon as the midwives get professional training, they become a desired labor product, and it's easier for them to migrate. We want people to be able to better themselves, but then we end up training people for export. And, so in some ways, making sure that there's a wide range of skills available to communities may be more cost effective.
No, I think, Sunanda, that's a really important comment, and I think it's in the envelope which we need to argue the the whole story that we've just talked about. So I think, thank you, that's been very helpful. I don't know if there are any other comments, but I think it's been a really rich discussion. Michael, do you have something to say? Go ahead.
Hello, Professor Sabir Mosa. Thank you very much for allowing me to participate in this so interesting issue Congress. I was lucky to have in my group Mr. Tijamaki.
Yes.
And I write down the result of our group.
Okay.
Before, yes, you can see it. So, but Dr. Tijamaki told what we discussed in our group. So thank you very much.
That's fine. Thank you. If you've put it in, whatever is there, we've got it. It's if either in the chat or on this group discussed, I think we'll hopefully catch it. So if you feel everything's been captured, great. Thank you very much. This has been really very good. I certainly found the feedback really rich, and I think that it will certainly be something I can, that we will put in a document that we are going to put together as AfroPHC. And I think there's some really important suggestions, concrete suggestions around developing a forum or supporting that kind of structuring of community health workers across the continent. So I think there's some really good, useful suggestions on the board, on the table. So Cynthia, as the other member of the executive board, do you want to make some closing remarks and then we can close from there? Cynthia, do you want to make some closing remarks? If you can unmute yourself and just say some few comments and then we can close. Let me just ask her to unmute. Well, thank you all very much. I think Cynthia might be having some challenges to unmute herself. I hope she can in the next 2 minutes, but thank you all very much. It's been very helpful. I think we will get all the recording will be available online at the same site as the registration was done. There will be also several documents that we've gotten from this discussion that we'll put up there. And thank you all very much. We have this workshop monthly, and we're hoping to try and have issues that are important. So please have a look at the website. There may be some date changes with the next one, but please keep a note of the website and any emails that we sent you. With that, thank you all very much on behalf of AfroPHC. It's been great discussion. Enjoy, and we'll keep in touch. Bye-bye.